Hi, everyone. Welcome to the launch of the Lown Institute's 2023 Racial Inclusivity Results. My name is Vikas Sani, and I'm president of the Lown Institute. We're so glad to have you all here today for this important conversation. At the Lown Institute, we believe in measuring what matters. That's why we created the Lown Hospitals Index for Social Responsibility. We use metrics that haven't been used before, like community benefit spending, overuse, pay equity, and of course, today's topic, racial inclusivity. Now, if you look at the bottom left of the current slide, you'll see how racial inclusivity fits with the overall schema, just so you have a little orientation. So our annual launch of the full rankings took place in July. And if you want to learn more about all those metrics, you can go to our website, lownhospitalsindex.org, and see the most current data. So before we get started, let's introduce today's guests. Dr. Uche Blackstock is a physician and thought leader on bias and racism in healthcare. She's the founder of her own firm, Advancing Health Equity, which partners with healthcare organizations throughout the country. Her forthcoming book, Legacy, A Black Physician Reckons with Racism in Medicine, will be released January of 2024. It's only a few months away now. Dr. Selwyn O. Rogers Jr. is an acclaimed surgeon and founding director of the University of Chicago Trauma Center. He was recently named an associate editor of the New England Journal of Medicine and also serves as a member of the Lown Institute board. Earlier this year, he co-authored a phenomenal piece in the New England Journal titled, "Aren't You the Valet?" And I highly recommend reading it if you haven't seen it already. Dr. Elena Mendez Escobar is co-director at the Health Equity Accelerator at Boston Medical Center. She's responsible for strategy there. She holds a PhD in theoretical physics from the University of Edinburgh and an MBA from MIT's Sloan School. Recently, the Boston Business Journal named her to their list of 40 under 40. So welcome to all of you. Uche, I'm really excited about your book that's coming out. I bet you are too. In a nutshell, can you tell us what it's about?
Well, first of all, thank you so much for having me here as a guest panelist, and thank you to the audience for joining. So Legacy, Black Physician Reckons with Racism is essentially, it's about being a second generation Black woman physician. It's about racism in medicine, both past and present, and it's a call to action. So essentially using both my mother and my own personal professional experiences to shine a light on the systemic issues like racism in medicine and healthcare. And I'm hoping that the book will really expand the public discourse around racial health inequities and the policies and changes we need to see happen to close those gaps.
That's terrific. I'm looking forward to reading it. Selwyn, 7 years ago, you became director, the founding director of University of Chicago's Trauma Center. Can you tell us a little bit about how that happened, how you got there, and how it's going now?
Thanks so much, Vikas, and thanks to the panelists and for this opportunity to discuss an important topic of racial inclusivity at our America's hospitals. What brought me to Chicago from a small island in Galveston, where I was serving as the chief medical officer, was an opportunity to right an injustice. As it turned out, there had been no adult level 1 trauma center in the south side of Chicago for almost 3 decades. And so, interestingly for me, as someone who had visited the city of Chicago several times, I'd never stopped to think that there was no adult level 1 trauma center on the south side of Chicago, which represents a population of about 650,000 people. And anyone would be hard pressed to find a city of that size that does not have an adult level 1 trauma center. So when University of Chicago Medicine came calling, despite the fact that I had some concerns about how hard it was going to be, it became for me a mission from God, if you will, a mission that compelled me to act once I knew. And that brought me to University of Chicago Medicine 7 years ago. How it's doing now? We opened in May of 2018, and we've seen over 20,000 trauma victims. Unfortunately, 40% of them, over 8,000, have been the victims of gun violence in the city of Chicago, and the work continues.
Thanks, Selwyn. I know there's a whole lot more there, and I'm sure I and others in the audience would love to hear more about it. Elena, you have an interesting background, theoretical physics, business admin. So tell us how you got involved with Boston Medical Center and the Health Equity Accelerator.
I think the thing that has always moved me was really fighting for injustice and things that are systemic problems that sometimes in our day-to-day life we blame on individuals, but really have to do about changing whole systems. So before BMC, I spent 10 years in consulting where I focused in Medicaid and learned about the design of big systems and policy and advocacy. And I joined BMC 3 years ago when BMC really was wanting to focus on racial inequities. Boston Medical Center was the first public hospital in the country and has a very long history of focusing on health equity, over 150 years. However, when we looked at our data, we saw the same gaps that everyone else can see, where our Black, Hispanic, Latino patients have consistently worse outcomes than non-Hispanic white patients. So we really couldn't stand and do nothing against that data. 2/3 of our patients do identify as Black, Hispanic, and Latinos. So we launched the Health Equity Accelerator with the intention of really shining a light specifically on those groups and transforming the way we deliver care in a way that is going to work for our community, because what we have been doing historically hasn't been enough. So we'll talk about it more, but it's clearly a very long road ahead, and are really excited to be part of this conversation with so many other systems across the country that are now really prioritizing an explicit focus on racial differences in health outcomes and really trying to figure out how do we do better healthcare for our communities.
Okay, and can I share that I attended their first ever Health Equity Summit last week, and I was a panelist, and I was just incredibly impressed with the work that BMC Health Equity Accelerator is doing around economic mobility in our communities, around the workforce pipeline. They really are and have become a leader in terms of advancing health equity. So thank you, Elena and Trina and the rest of your team.
Yeah, I'll definitely second that. It's been pretty clear, both being in the Boston area and from our own data and work we've done, that BMC is a national leader. So we're really glad to have you today. So let's talk a little bit about hospital markets and their segregation. So as we all know, and as you just heard, communities of color are disproportionately affected by chronic diseases. They have lower life expectancy, and they're less likely to have the kind of insurance that's preferred by hospitals. COVID, I think, was a clear, stark reminder of that reality for everybody in the country. So we have a kind of paradox. These communities have the highest need for care, but have great difficulty accessing it. So in Boston, for example, the Back Bay neighborhood, which is primarily white, is just 2 miles from Nubian Square, which is primarily Black and Hispanic. And the two communities have a 23-year gap in life expectancy. How does anybody look at that and not get shocked? So to get a sense of how hospitals fit into this general social dynamic, we created the Lown racial inclusivity metric. Patterns that we might become aware of but take for granted can suddenly become quite clear and visible when you look at data, especially if you look at it the right way. So for example, here's Northwestern Medicine Palos Hospital in Chicago, represented by the blue pin. The blue line is what we call the community area. To get that, we look at where the hospital's patients are actually coming from, and we calculate travel times. And then we use the radius of that travel time to represent the whole area to define where the hospital's patients could come from. So then we use both traditional fee-for-service Medicare and Medicare Advantage, which is new this year, to compare the demographics of both the community area and the demographics of the patients that the hospital actually sees. Now, you'd expect them roughly to match, like in a null hypothesis, if the only thing were how far it was, you'd think they'd more or less match. And they do, actually, for many hospitals, maybe even most hospitals, but not all. So let's look at this hospital as an example. So the orange map on the left is where the hospital's patients come from. On the right in purple shows where non-white Medicare eligible patients live, according to the census data. So you can see that while the majority of communities of color are to the east of the hospital actually sees disproportionately more patients from the south. So both areas are close to the hospital. The patients are only coming from one of them. So this hospital is less inclusive than expected by our metric. Now let's look at a more inclusive hospital that's not too far away, and that's John H. Stroger, also mostly known as Cook County Hospital. So on the right in purple, you can see there are non-white Medicare eligible patients living in relationship to the hospital. And on the left in orange, you can see where the hospital's patients are actually coming from. So those two maps look pretty similar, indicating that most of these hospitals' patients are coming from the communities of color that are around them. Now, with this data, we actually calculate a specific percentage of white and non-white in the community compared to the hospital. And that's how we can quantify a lot of these things. So here's what that looks like for John H. Stroger or Cook County and for Northwestern Palos, the same two hospitals that we showed you in the maps above. If you look at just the people of color in the community, John Stroger's hospital community area is 53% non-white, and Northwestern Palos is 35% non-white. But when you look at the actual demographics of the patients they're seeing, Stroger's are 78% non-white. In other words, they're kind of over-serving people of color by 25% more than you'd expect using our metric. Northwestern served only 21% non-white, so they're underserving even by their own community area by about 14%. So that's how we derive the metric and how we can do some quantification and some mapping. It's important to point out it's not just Chicago. We've identified 11 metropolitan areas with high proportions of hospitals at either ends of our national inclusivity metric. In other words, these 11 metros have both the most and the least inclusive hospitals within the same area. Now, I think I should point out it's rare for hospitals to fall in those two extremes on our metric. Only 3% were designated as most inclusive and 6% as least inclusive. But in all these metro areas, there's racial gaps, and those are gaps in life expectancy, some of which are actually really large. For example, the life expectancy gap between Black and white residents in St. Louis County is 9 years. And the life expectancy gap between Black and white residents in Cook County, where we were just looking, is around 8 years. That's a lot to take in, but let's go to our guest panel and discuss. You know, a lot of what we're seeing in these maps, of course, has been baked in for decades. It's, you know, been baked in by redlining, by the segregation of the labor market, the link between employment and insurance coverage. You know, there's so many factors, hospital reimbursement patterns. And I think it's fair to say, I think we'd all agree that these are all structural factors that affect who in our country has access to healthcare and where. So in many ways, I think what we're illustrating are the long-term effects of structural racism and classism. But to our panelists, what do you make of these results? Do these patterns ring true? Are we getting it right? Is this metric actually illuminating something for you? So Uche, let's start with you, and then let's just go around and hear your reactions.
I mean, I think probably like the other panelists, I'm not that surprised by these results. And I think I looked back at some of the data from last year. Was this the first year, or we did it last year too, right?
No, we did it last year, yeah.
Yeah, and it seems like it's pretty similar. I mean, I think, you know, I've lived in New York City for the majority of my life, and we see similar trends here, although I didn't see any New York City hospitals listed on there, and I'm quite surprised by that actually. And I'd love to just sort of know what your impressions were in the analysis of the data. Also, I'd be interested to see the breakdown in terms of academic medical centers, because we know that often it's the academic medical centers that are often in communities of color, but they disproportionately underserve people of color, and also disproportionately underserve uninsured people as well. So that's just sort of something I thought about looking at those metro areas.
Yep. I'm going to keep going, but just very quickly, I'll say, these 11 metro are the ones that just landed in the extreme tails. But the story is actually similar for many other metro areas. So Elena, what about you? I know your responsibility is primarily strategy and moving things forward, but before we get to that, can you just give us a kind of frontline report on is this real, and what's the reality? What are the problems you've identified in Boston?
Yeah, I think unfortunately we are all seeing the same data and the same reality so consistently. I mean, in addition to the life expectancy data that you showed, we see across the country differences in pregnancy, mortality rates, morbidity rates, death rate from different cancer types, complications from diabetes, hypertension, all of them always consistently having worse outcomes for Black patients, Hispanic, Latino communities, and Native Americans, among others. So this is so consistent and so universal that, as my colleague, Dr. C.A. James always says, it unfortunately has become the expectation. People expect these differences to exist, and sometimes that can paralyze us. We accept it as the status quo. So what it's really important is, I think, that we don't take it as an expectation. It shouldn't be this way. It is, of course, decades, if not centuries in the making. So it's going to take a lot of effort and intentionality from all of us to reverse it. And we need to focus on that, right? We need to move away from continuing admiring the problem and think about what is it that we can do to change this. And it is going to take going much outside of our comfort zone, right? Because what is clear is that whatever we've been doing for the last few decades is not working for our communities. And we need to do new things. And part of the challenge is that oftentimes we don't really know yet what will work. And it requires taking some risk, getting outside of what we normally do, going upstream, trying to address really deep root causes around economic mobility barriers and things that are not typically within the scope of what healthcare systems think about. But we need to go there in very bold ways to really be able to reverse this problem.
Thanks. That's really clarifying. So Selwyn, I know you have experience with multiple hospitals across different cities. First Boston, where we first met, Galveston, Philadelphia, and now Chicago. Are these patterns something you're seeing most everywhere you've been? What are your thoughts?
Yeah, I'm going to say what she said, what both Elena and Ocha said. These are systemic issues across all of our United States of America. And when you see systemic issues, you got to think structural. I mean, what about this is fixed by a system that provides opportunities for some and disproportionate lack of opportunities for others? And unfortunately, that in America translates into less opportunities for communities that are historically marginalized over centuries. And we see it manifested in health outcomes. Obviously, hospitals and clinics are only represent about 20% or so of the contribution to health outcomes. Many other factors, poverty, access to jobs, economic development, like Elena shared, agency, one's ability to affect change in your local political environment. Those are all factors that affect health outcomes. But for this topic today, we're focusing on hospitals. And I think without a doubt, we see the results with respect to maternal mortality, trauma outcomes, something that I do every day, healthcare disparities related to cardiovascular disease, related to strokes, related to cancer, and those manifest in premature morbidity and mortality. Because you quoted 8 years, I think 9 years, Cook County and other parts of the city of Chicago. But if I'm going to be hyper local for a second, Washington Park, where I'm sitting in my office, is the park right across from my hospital's trauma center. Washington Park is a community, and the average life expectancy is 16 years less than Streeterville, which we often think about the magical place where there's skyscrapers and the being of Chicago. So 16 years of life lived, no comment about the quality of that life, but 16-year life expectancy gap separated by 8 miles of distance in one city, great city called Chicago.
Indeed. Well,
Can I just add one thing?
Yeah,
I just feel like so these inequities also often get perpetuated by sort of the culture of the institution. So, I had the experience of working at a public hospital and an academic center that were affiliated here in New York City. And it was to the point where even the EMS workers would never bring a certain type of patient to the academic medical center. And that was because whether it was explicit or implicit, they knew that they would maybe get in trouble or be reprimanded for that. So we have to think about, like, in coming up with solutions, thinking about how a lot of these inequities are perpetuated by what has become embedded in the culture of places. Yeah.
Completely agree. The thought experiment that preceded our generating this metric and thinking about this the way we are really was, what would a perfectly functioning healthcare delivery system look like? How would people make their choices about which hospital to go to? And you presume it would be distributed, it would be accessible by neighborhood, by this, that, and the other. And the racial composition would not really vary in a sense. It would be truly reflective of the community. Maybe there's some specialized skill or technique or something, but none of that. So I'm fond of using this. I might have used it before on this, on our releases, but it's almost as if you were building 2 airports, half a mile apart, and different people based on race or income go to one airport and the other. When we put it that way, it seems crazy. And if you think of healthcare and hospitals as a social good, it is crazy what we're doing.
Yeah,
but that's where we've ended up.
Yeah, it's a 2-tiered system, and we really have to acknowledge that explicitly.
Yeah. I'm just going to take one question from the audience, and then we're going to keep going. But before I do, one thing, New York City did have some high-performing hospitals, but overall, we actually expanded to include the entire metropolitan area this year, and so the numbers changed a little bit for that reason. So a minor point. So one question from the audience is, if this is all based on Medicare data, how do you compensate for populations that are not on Medicare, like birthing, pediatrics, etc.? And the short answer is we don't. We would like to, and we intend to, in the coming year, be incorporating Medicaid data, but we haven't developed that yet. But I think there's another point I would make about it, which is we're showing data that's Medicare based, which means the revenue in the moment to the hospitals is identical. So, what's driving this is probably a lot of cultural inertia and past behavior on the part of both patients and hospital systems. So in that sense, using Medicare is actually a little bit reflecting sort of a broader baked in pattern. At least that's my view. So anyway, let's keep going. So we've previously shown you some hospitals that are overserving from communities of color in their region, but now it's time to give credit where credit's due. So the countdown for the 2023 most racially inclusive hospitals. Number 10, Emory University Midtown in Atlanta, Georgia. Number 9, Methodist Hospitals in Gary, Indiana. Number 8, Grady Memorial Hospital, again in Atlanta. Number 7, St. Charles Madras in Madras, Oregon. Number 6, South Coast Global Medical Center in Santa Ana, California. Number 5, Metro Nashville General Hospital in Nashville, Tennessee. Number 4, Penn Presbyterian Medical Center in Philadelphia. And now the top 3. Number 3, University of Chicago in Chicago, Illinois. This was University of Chicago's second year in a row in the top 10. Number 2, another top 10 winner, John H. Stroger, I guess you say, Cook County. And our number 1 hospital, most racially inclusive in the United States, Boston Medical Center, right here in Boston, Mass. So first of all, congratulations to all these top performers. We're really delighted to be able to showcase certain hospitals in the country that often don't get their due. So here we are, Elena. Your hospital earned number 1, the number 1 slot for racial inclusivity, and it's consistently in the top in our metric. So, increasingly we're getting people asking us for tips on how to improve their performance. So is what you're doing at BMC, is that replicable? How would you characterize that?
Yes, certainly we intended to be replicable. I wouldn't dare to say that we've solved this problem. We're putting a lot of effort and energy behind it, as I think many other hospitals are throughout the country. And as Uche was sharing earlier, we held last week our first annual Equity Summit to foster this conversation, right? Because we all really need to learn from each other and from the innovations that are happening in the different systems to solve this problem. It's going to be a group effort. But I can share a few things that we have learned over the last few years that we've been doing this work that may be helpful. The first one is really this idea of getting out of our lanes and going upstream. As we've talked about, many of these issues are so rooted on barriers to economic mobility that Black communities, Hispanic communities have faced for decades, and we need to change those at the top. And this can take many forms, from including financial coaching, financial even services and products in our healthcare system, to being very thoughtful about who we employ, how we employ them, who we're promoting, and our role as one of the biggest employers in most of our areas. We can have a huge difference in this. I know there are a lot of people on this call that listen that are involved in policy. And, these also take some policy because of the strict lanes usually of how things get funded, to be able to use healthcare dollars to really invest in some of these economic mobility important issues could unlock really a lot of progress there. The second piece is really the quality improvement angle and thinking of health equity as a must-have to have quality care. We have found that one way that racism impacts health outcomes is by delaying treatment, delaying diagnosis. And that's something where we can change systems to kind of remove the opportunity for our own biases to produce those delays. And my colleagues recently published a piece specifically looking at the time that it takes from the decision for a patient to undergo a C-section until the time that the surgery starts. And when the research started, when the project started, Black patients, this time from decision to incision was 98 minutes, versus for non-Hispanic white patients, it was 78 minutes, a 20-minute difference, which creates more opportunity for complications, which were indeed happening. By the end of the project, by standardizing and setting a goal that this had to be less than 60 minutes of a process, it actually got better for both Black and white patients, but improved a lot more for Black patients. It almost halved So from 98 minutes to 50 for Black patients and from 78 to 58 for white patients. This is just one example, but there are so many other instances in our healthcare systems where we see we can do more to avoid delays in when cancers are screened and diagnosed, when treatment is initiated, and navigating patients to their options quickly, and really enabling real agency of patients by sharing information with them about the conditions, the resources available in a timely manner and in a way that is relevant for them and for their daily lives and their communities. So I think this has been a really important piece of the work that we've learned. And then the last piece would be around really partnering with community organizations and rethinking and rewriting, as we say, our healthcare systems to the needs of our real communities. We can't have one size fits all approach for all communities everywhere, because different communities have different needs. And that sometimes may mean issues around access to interpreters. Other times it means being able to provide more care at home, remote monitoring, and really saving people time that they don't always have to come to a care provider to receive their care, and really thinking differently about how we're delivering the care in partnership with community organizations. We have done, we did a lot of work with partnerships around the COVID vaccine, with local churches, with our local YMCA organizations and so forth, to really be where our community is, understand their needs, and really adapt the services that we're offering to what they needed.
Thanks, Elena. I may come back to you but, with the same question I'm about to ask Selwyn. You've described a lot of good things that your institution is doing to serve the population they already have. And I'm kind of curious, what could other institutions do to change the footprint of the people that they do serve? And, it's a tricky question, and there's always a lot of friendly competition between systems, including in Boston, though everyone, at least in the Boston area, shelved it during the COVID pandemic in a way that I thought was actually a model for how we should be in the future. So Selwyn, your home base, University of Chicago, #3 this year, also in the top 10 last year. Can you tell us what University of Chicago is doing right? And maybe you could tackle what other institutions in the area might want to emulate.
Well, I'll start, Vikas, by saying it's a journey, not a destination. This is not one of those things that you ever arrive. You are always striving to arrive. And I think that's an important framing. So this is never rest in your laurels, we're here, we're #3, we're good enough. Nope, 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 nope. This is constant vigilance to embed equity in everything that we do, our policies, our approaches, our access. One of the things that I think we have, and I'll highlight 3 things. First of all, start with the word community. You have to relate to the community in which you live. I think for us, 60–70% of residents of the South Side are Black and Brown people. I think one of the things that we have done right is that we have a community activity council, community action council, where we have 20 or so representatives from the community who provide, if you will, informal guidance, advice to hospital health system leadership. And I think that's a very important tactical approach to get at what the community thinks they need. That's led through our Urban Health Initiative, which is an intentional program that for Mrs. Obama, when she was here, Southsider originated, currently led by Brenda Battle. I think those are examples of structural approaches to tackle the problem. The second is you have to be intentional. I mean, I think Elena said this well. You have to be willing to measure this stuff. And so if you're not willing to measure key performance indicators that align with quality care, time to X, time to Y, and we do that already anyway, right? In your field, cardiology, time to cath, time to balloon. I mean, these are things that we are graded on. So why are we not stratifying them by race and ethnicity? And if you can, socioeconomic status. Those are modifiers that are not modifiable. So let's do the things that narrow those deltas between groups that are artificially constructed, like race. And then my last comment is one: just because it's hard doesn't mean we shouldn't do it. So that's an aspiration. These things have been embedded this way in this country for centuries, from chattel slavery to Jim Crow to the prison industrial complex. Well, okay, those are all big things that a health system can't really affect change on. Can't change the past, can't change the present, but we can influence the future. And I think in the context of that intentionality about how do you design programs, how do you measure things that affect real people in real communities in their real lives, or things like their health outcomes. I think those are the three, if you will, interlocking approaches to actually get at making equity a journey that we all need to share and embrace. You're on mute.
Whoops, cardinal mistake of the Zoom era, sorry. Audience questions are piling up, but I know you want to get a few words in. Uche, what are your thoughts and reactions? What could other hospitals be doing that they're not doing now?
Yeah, no, and I was actually also looking at some of the audience questions, and I found the question about, is it possible, about maybe, sort of the culture of the hospital maybe being a factor in patients not feeling welcome or not feeling invited. And I see Judith posted an article about that. And I feel like, this is not rocket science, right? This is really about centering the communities that your hospital has a mission to serve. And, it's about understanding what, Elena and Dr. Rogers were saying, that it's about health not just being about health, and healthcare not just being about healthcare, that we are recognizing the upstream factors like how systemic racism, how capitalism, how it impacts the social determinants of health. So thinking further upstream, and really, I think for healthcare institutions having a better understanding of what we call structural humility, right? So understanding how interpersonal interactions and power hierarchies within healthcare impact the communities that we serve. So all that to say is, I think that health systems should look more at like community governance models where there are community members, employees, even patients involved in helping to develop some of these health equity metrics, to ensure transparency, which is very, very important in terms of the data. Making sure the community is aware of what the data shows, and also how these institutions are going to hold themselves accountable. So I think it's about, building a trust that was never there in the first place. Let's be honest. It was never there in the first place. So what are going to be the trust building, the multi-level trust building strategies that we're going to use to really truly become a racially inclusive hospital that is fulfilling its mission?
Great. So much more to talk about. A question from the audience. What suggestions might you have for local employers who want to prioritize the health equity of their employees, for their employees? Should they consider partnerships with racially inclusive hospitals to ensure that their employees have access to culturally sensitive providers? This is an area that's not usually talked about in marketing meetings or meetings about business plans. At least my guess is it's not. What do you think? Let's start with you, Elena. We'll go around the batting order.
I think this is a really interesting question, and it goes back to what Uche was just saying about how systemic this problem is, and what we were talking earlier. The analogy of the two airports really stuck with me, right? So it's not only as if we had two airports in the same city where people of different races are going, but also these two airports are very differently funded. And the airport that has the least funding is the one where all the Black patients are having access to, right? So really thinking about that is extremely important. What are the differentials in how we're funding system, and are we creating a two-tier healthcare system just from the funding? And to bring that back to the employers, I do think there are huge levers that employers have in reducing those differences, right? Because a lot of those differences in funding, they come from two places. One, what is the share of their patients that are uninsured or publicly funded? But also number two, what are the commercial rates the different hospitals can set and negotiate, right? And employers can influence that and can ask their health plans when they negotiate with them that they provide a smaller spread in how differently they're paying hospitals who are more or less racially inclusive. So they can truly influence the whole funding differential of the system by their own negotiations with their health insurance and voicing what's really important to them.
Got it. Well, so I want to talk a little bit more deeply about solutions. I mean, I think what this conversation is telling us so far is that, you know, maybe it's just my belief, but that an equitable system in the US is possible, but there are just so many layers that we have to unpack to get to the heart of it. So we know hospitals say that their doors are open to anyone. But clearly there's more to it. So first of all, there's what's within the ability of current hospitals, like hiring diverse staff, decisions about where they build new centers for primary care, for example. But the results also show, and the conversation I think has indicated, that there are deeper structural things that hospitals are not going to be able to fix themselves. And in that arena, I think it's going to require concerted effort between hospital leaders, community leaders, policymakers. So to me, it's pretty clear that what we need is strategic, systematic approaches and changes. So just a few thoughts on that reaction. Selwyn, let me start with you. What do you think are the major structural barriers to dissolving the effects that we're seeing? And what would it look like to overcome them? Do you have thoughts, as Elena suggested, on the kinds of things beyond the actual clinical encounter? What would it take for all hospitals in Chicago to be equally inclusive?
Yeah, I have a lot of thoughts. So I'm not shy. I go back to a little bit about how we pay for healthcare, right? So what do we pay for? We pay for doing stuff. So there is incentives to do stuff, and that includes interventions like colonoscopies, interventions like coronary stents, interventions like operations. There's not a lot of pay in not doing stuff. And there's even less pay in preventative things that, for the most part, fall into the public health realm. And we saw this, and we continue to see this with COVID. The lack of a very robust public health infrastructure led to hundreds of thousands of likely unnecessary American deaths because we didn't have a very robust public health system. And we have been overly focused on the medicalization of everything in healthcare and its commoditization. So when we pay for things and we think that adds value, we know that we have both unnecessary care, and we know we also have, at times, disparate care for things that should happen. And unless we right-size those things, we will continue to blow by 20% of our gross domestic product on health care, but not on health or wellness in the United States. So I think that reframing is big, but probably at some foundational level what we should do as a country if we re-engineer our health system. On a more local level, hospitals, health systems are big economic engines of the communities in which they serve. And so if you're a big economic engine, buy local. And if that means looking at sourcing food, sourcing products, sourcing supplies from the local environment that would lift up local communities, that creates jobs and other economic vitality that then can become a virtuous loop. One of the things, for example, some in Chicago are looking at health systems is looking at where we get our linen cleaned, right? So if we outsource that to some big company far away, that helps that big company far away. But what if there is a local solution that could do the job just as well? And I think those are concrete examples of creating, if you will, micro industries around healthcare that can have reverberating positive impacts in the communities that are often historically marginalized, historically disinvested in.
Thanks, Owen. I just want to make a comment because I think what Elena said about, helping or employers participating in creating an environment in which the pay differentials, the payment differentials for different health plans, different populations, and all of that are reduced. I think that's almost one of the fundamental problems, right? We have a segregated insurance market, and we have that because of the way insurance was constructed after the war. It's employment linked. The labor market itself has a lot of segregation. So I just got to say that it seems logically pretty obvious that if all patients meant the same revenue opportunity for everybody all the time, whether it's through reference pricing or a Maryland model or a single payer system, which would be the most rational, I think we'd go a huge way towards removing some of the structural impediments. But I think the examples from all over the world where we actually have government-sponsored insurance and the like show many of these cultural elements persist despite the payment reform. So it needs that and more. So Uche, you left an academic medical center in 2019. You detailed your experiences in a Stat News article. How could hospitals do better by their patients and by their staffs?
Oh, such a good question, and so many different answers to that. But I definitely think we have to hold these academic institutions accountable because of the funding they get. They have a mission to serve, to serve especially marginalized communities. But I did want to just talk about more about the centering of communities of color and Black communities, how important it is. So I mentioned this the other day when I was at BMC, but really an understanding of how systemic racism works, that we have data that shows that communities that have high levels of interaction with police, so whether that's police brutality, whether that's being stopped by the police, they're more likely to have mistrust of the healthcare system. They are more likely to have unmet needs. So they're more likely, even if they're not feeling well, right, to decide not to go to the doctor, even if they do have access, right? So we really have to understand the myriad of ways that systemic racism plays out. So yes, I think single payer would be amazing, but do I think that would end the racial inequities, health inequities that we see today? I don't know how substantially, right? Because we're still going to need, I think as Susan Rogers pointed out, we're still going to need a diverse healthcare workforce, right? We're still going to have a better understanding of how racism plays out between the way these communities interact with, the criminal legal system, the educational system, employment system. So I do think that, moving forward, we need to think more about these upstream factors. It is critical that any interventions policy-wise address the upstream factors that are culminating in these horrible racial inequities that we're seeing and resulting in this racial inclusivity or exclusivity data that we're talking about today.
Thanks. And let's close it out and then keep going with audience questions. But Elena, you get the last word on this. Back to the question I originally asked, you guys are doing an amazing job. You're number one in racial inclusivity. But the question really is, what do hospitals that don't already have the kind of patient and population footprint that you do, what do they do to do better? It's one thing to signal that you're moving in that direction. It's another to operationalize it in a way that has impact. Any thoughts on what would actually make progress in other institutions?
I think the biggest thing, if I had to synthesize into one thing, is building on what Uche was just saying, truly listening, what is the community saying, partnering with them, and then figuring out how to make that happen. Because oftentimes the way we do planning or strategy for health systems, we're looking for the next biggest thing that is going to produce the most growth or the most margin or whatever it is in service of the mission. But that's not always what the community needs, right? Because our financial system right now, as we're all saying, is designed, it produces exactly the results that it's designed to produce. So we have to really listen to what our community needs and actually change the financial incentives so that we can make that happen. And, there are very small examples, like, for example, our community, we have a lot of people who would prefer a language other than English in their encounters. And interpreters are not a reimbursable service. So if you're looking at your financials, it's not in your best interest to hire, a lot of interpreters to be able to have them readily available without a wait time to serve your patients, because that is not a reimbursable service right now. But that shouldn't stop us. If our patients are telling us that's what they need for good care, let's then change the financial system. Let's, advocate for that reimbursement. Let's change the policy so we can actually meet that need. So I think just shifting that that framing of really focusing on what really needs to happen in partnership with our patients and our communities, and then figuring out how do we change the system to make that happen.
Yep. So here's a question from the audience that I think links directly to this conversation. And maybe I'll toss it to you, Che, which is, it's at the sort of intersection of payment and culture. So do you think academic medical centers, we'd see more success from academic medical centers if the incentives for them were different? Public health, community medicine, students, everybody in those settings, if the incentives of the institution as a whole, and I assume the questioner means financial incentives, if those were modified, would that actually make a bit of a difference beyond what you were already saying about single payer? And to that, let me append a question, which is in relationship to what Elena was just saying, would you say there's an opportunity for academic medical centers to join with communities in advocacy for those kinds of changes rather than be responsive to community demands? Could we not imagine a coalition where everyone's on the same side to push for change?
I mean, that would be ideal. Of course, that would be ideal. I have to say, and just be transparent, like, I hate the business argument for being humane. Like, it just, and I know that may sound naive, but, I wish that we didn't have to talk about financial incentives. I think that financial incentives would move the needle somewhat. But again, I think that there's so much pathology, and serious pathology, embedded in the culture of these institutions that I think it would have to be a multi-pronged strategy. But of course, I mean, working with community-based organizations or organizations already embedded in those neighborhoods that know the community members, know the needs of those neighborhoods well. Of course, like, I feel like that should happen. Like, common sense. The fact that that's not happening is unconscionable to me. So again, yes, I think it could be possible that these financial incentives could move the needle for our academic medical centers. Yes, they should be working with community-based organizations, but I do think that again, multi-pronged strategy is required because the culture is so deeply embedded that I feel like the change would be limited.
A quick follow-up on that. This is, I think, mostly for academic clinicians. The question is, how about, could we or should we change the incentives in academia around publish or perish? Because in many ways, this is now me editorializing, in many ways that often creates the cycle of admiring the problem and then re-admiring the problem and then re-admiring the problem.
Yeah, and I know that when I was leaving academic medicine, I know at my institution, there was a movement towards really thinking about valuing other types of contributions. So, whether it's mentoring, whether it could look like, the work that you do with your community-based organization, like that sort of counting towards promotion and then incentivizing for that. I don't know how much that has shifted. But again, it's like, one of the reasons I left academic medicine is because I felt like they did not have their priorities in check. Like what was valuable to me, what I thought was important to me was not important to them. There was a misalignment. And I think that's the case for many people in academia. Oh, because you're muted. Okay. So
sorry, go ahead.
No, go ahead.
No, I was just going to say that I've got my eye on the clock. And so one of the things we have to figure out is whether we're going to go over time, because this is a good conversation. I don't want it to stop. That's all. So
if I can pick up on what Uche said in reference, there's still obviously a very dominant edict in academic medicine of publish or perish, but increasingly many departments are beginning to incorporate elements of advocacy, elements of community engagement, elements of true rewarding people for being an exceptional teacher, things that are historically taken for granted, but it's a skill, just like any other skill, and it is a skill to be NIH funded. That's a skill. But there's also a skill to be deeply embedded in communities in which you serve, especially marginalized communities, however you want to define that. And if you're having impact in those communities, that actually is academic productivity. We just have to get better at measuring it.
Yeah.
But it does not mean that it doesn't involve work and sweat equity and building relationships and having true impact from the community's perspective. You can write 100 papers and the community never feels it, never touches it. But you engage with the community to help your health system be better at measurement around C-section rates or measurement around access to percutaneous coronary interventions. And the community feels that, that's impactful.
Yep, absolutely. Well, let me just get a quick show. Uche, Selwyn, and Elena, can you stay a few more minutes? Because I think we'd all love to keep going. That's terrific. So we're at time. We're going to keep going. But before we do, let me just say our next data release is going to be on hospital overuse and low-value care, something that Selwyn has mentioned a few times. And it's something that we'll be highlighting. So stay tuned, and you can subscribe to our newsletters by going to our websites and keep up to date. You can also follow us on Twitter, LinkedIn, Facebook, and TikTok. And a recording of this event will be posted on YouTube and Vimeo shortly. So those of you who need to leave, you can catch up the rest later. But let's keep going. There's another question from the audience. And maybe I'll toss this to you first, Selwyn. But many hospital systems that we speak with, this is the questioner saying, that they're shifting their care to the most appropriate setting, into the community setting, as opposed to the acute hospital campus. So, I think we know this is a trend. It's a generalized trend for lots of reasons. Selwyn, first, are there thoughts on whether that kind of moving out of the hospital tide is going to help reduce health access inequality or not help or make it worse?
Well, it's complicated. Because it all depends on how it's done. So one way to do it is to move out the less desirable health plans, less desirable patients, those who have more social needs out in the community, and say that you're doing a great job. But the better way to do it, or the best way to do it, or the most equitable way to do it, is to provide care for everyone in the right place at the right time. And so if you have a community-acquired pneumonia and you don't need to be on ECMO, you shouldn't be in the tertiary care academic medical center, because that bed is ideally used to serve someone that needs ordinary, most advanced care. And so that way you get the sickest people in the hospitals that need them for access to the most highest level of care. And for those people who could be well served based on their diagnosis and the appropriate severity of their illness in community settings within a health system, everybody wins, right? You had the lower cost health center providing the care that you need, ideally locally, because we know that particularly communities of color, sometimes transportation is a barrier to getting the access to care that people need. But then if you got sicker and you needed to be on ECMO, you could immediately get transferred to the higher level care in a seamless fashion. That'd be ideal. I think we know that increasingly hospitals are, if you will, right sizing. They're getting smaller, not bigger. They are intensifying what happens within the hospital and trying to de-intensify other things that can happen either in lower cost settings and or home. And I think that overall will be a good thing for the health system, as long as we ensure that that is done equitably and intentionally.
I agree. I mean, there's a whole hospital at home movement now, and actually a lot of it's been pioneered in parts of Chicago. But I'm also reminded of the deinstitutionalization movement for mental illness in the 60s and 70s. I'm old enough to remember that. And part one was the deinstitutionalize. Part two was provide the support in the community. Part one happened. Part two didn't. So I'm really curious, Elena at BMC, are you guys seeing this trend? Are you part of it? Moving care out of the hospital, moving it into the community. What does that look like? And what are the prospects for doing that equitably?
I think this is so important. And as you are pointing out, it's important to do it right. And it's not about, moving, as you said, undesirable patients to places where they're actually going to get less quality care, but really making sure that it's about providing care in a way that it's more convenient or even possible for our patients. One example I can give, and it's not only transitioning to some other institution, but sometimes it may mean using more telemedicine, remote monitoring, and things like that. So one example I can give is in our pregnancy work, we've been able to identify that a lot of the complications of our Black patients come from preeclampsia and how quickly it's diagnosed and how quickly it's treated. 18% of our Black patients will develop preeclampsia in their pregnancy. That's a very high number. You may decide that you want to have all your Black patients at some point on their pregnancy just come to the doctor's office to check their blood pressure once or twice a week. That's not possible for a lot of people. That may require taking half a day off work. They may not be able to do that. They may require childcare to do that. It's a very high ask. Instead, we are giving patients a remote blood pressure cuff where they can do it daily at their home. The data is sent to their doctor, their nurse, automatically. They don't have to do anything. They don't have to text it. And with that cuff, a lot of information also comes where they now understand a lot more about the risk and when they should actually come physically to the hospital. And that has really accelerated how quickly we can diagnose preeclampsia and how quickly we can treat it, because we're building real agency in the patients and providing care in a way. I hate to use convenient because it makes it sound less important than it is, but in a way that does fit into their lives and their childcare needs and their job context and everything. So considering keeping the accountability of the high quality care for the patients, but doing it in different ways that really make it possible for the patient to be accessing that care.
If I can tap onto that and say what she said in terms of what Elena just said, Clayton Christensen, formed the context of the framing of disruptive innovation, and healthcare needs disruptive innovators, because we can't just throw more money at the problem. So we really have to be innovative in a disruptive way to get people the care they need in the places that they need it. And that's one way that we can have innovation that leads to more equitable care. Obviously, there's been a lot of talk about AI and ChatGPT and all, but it's not just about technology. It's about doing the things that we currently do differently, fundamentally differently, with an equity lens.
Yep. Well, I'll underscore that. Certainly, Clay Christensen's concepts have been celebrated primarily in the business community and driven by market mechanisms. But I think the concept is reasonable to apply elsewhere. But if applied elsewhere, I would just underscore that equity and equitable solutions to these things sometimes require non-market elements as well. So. Uche, do you have any thoughts on the transition of care or the changes in the delivery of care? It's a big, complicated area. I'm not sure we need to get into it much, but if you have any thoughts.
The only thing I'll say is that, I know like during the most acute parts of the pandemic, I know definitely here in New York City, we found that more people of color were going to their FQHC to get vaccinated because those were embedded in their communities. And that's where they got most of their care. And so that kind of model where, we're moving out of hospital-based to community-based, to me makes sense on many different levels.
Yeah. Yeah, I'm a big fan of it. One of our board members, Michael Fine, was health commissioner in Rhode Island. And, he's been championing a concept of a neighborhood health station, one for every 10,000 people in the United States. I think it's a fabulous idea. It would require major structural changes and investments, but it's the kind of thing that the payoff would be there if we were able to initially make the investment. We're kind of going to wind it down, but here's one last question from the audience. How do you all, actually I have a couple, but some states are considering passing measures to crack down on DEI efforts for hiring and what health systems, hospitals can do in those areas. So my question is, there's been a lot of controversy. I could see arguments for saying hiring of a DEI officer is not enough. You got to go forward. But sometimes it looks like, the impulse is to say, we haven't seen any results, let's go backwards. But hospitals themselves can take a proactive stance, and certainly in terms of serving their own communities and having a workforce that truly represents their communities and their community area as we've mapped it, for example. There's a lot they could do. Uche, what do you think? What should they be doing? How could they do a better job?
I think the idea of health equity should be integrated into every aspect of an institution's strategic plan. Like, it shouldn't be up to one person in a DEI role to fulfill all of their DEI goals. And I also do think that while a diverse workforce is incredibly important, again, just like single payer, it's not going to be the only solution to addressing racial health inequities. But I think it's all about, obviously, one, being intentional, two, about really allocating the resources needed for these efforts, and 3, empowering the people that you're going to place in these roles to make sure they're not just figurehead roles. And then 4, have metrics that you're going to be held accountable to, and make sure that you're transparent about the whole process. And if you fail, make sure that the community is also involved in that kind of restitution process.
A question for Elena, maybe for Selwyn, and that is the role of community health workers. Are they currently adequately integrated in hospital services and outreach? Do we need more funding? Do we need a transition? Who's doing this really well? Is BMC doing this as well as you'd like?
We're definitely using community health workers a lot in our system, and we would like to use them more. There's a lot of room for growth in that model, in terms of not only funding the model, but also structurally setting it up in ways where it's set up for success. As you mentioned, being really integrated in the healthcare system, having training that is more consistent. We've done a lot of work with our training and our supervision and reporting structures of our community health workers, so it doesn't inadvertently create racial tiers as well. And I think there is an area where we have a lot to grow our community health workers. What is consistent is that they always add so much value to both the patient experience and the healthcare outcomes. And it's something that needs to be scaled, and we all need to invest in doing it better as a job experience for the community health workers, as well as a huge asset for the healthcare delivery system.
I echo that and add another layer. So with respect to intentional violence, we as a society don't have great ways at primary and secondary prevention that are scaled. And one example of secondary prevention is community violence intervention programs that takes people that are already at risk, people who have actually experienced community violence, and wraps around services and programs around them to try to insulate them from re-injury. That's a specialized area for which not everybody can do it. People with lived experiences are probably the best suited. But we have to invest in those programs, and there are pockets of them across the country. The Health Alliance for Violence Intervention tries to coordinate and professionalize this work. But certainly in the city of Chicago, there are lots of groups doing some of this work, but not at scale. And I think if we're going to really think around the issue of prevention, we're really going to have to be more intentional about scaling up these types of community-based programs.
Thanks, Selwyn. Well, I think we're going to wrap it up. I can't resist here just making the observation that this conversation has really been very rich, and in terms of a solution set, I think I could paint a picture that would be pretty darn exciting. I mean, imagine a robust transition to community workers, community health workers, community nurses, neighborhood health stations, a diverse hospital workforce, attention to those zip codes that are really not getting the attention they deserve by a given hospital, a single payer system or single pricing of some sort, and the appropriate application of technology. And suddenly that's a healthcare system that would be best in the world. Absolutely. And something that's really interesting to contemplate and set our goals towards. So thank you one and all. Thanks for coming. Special thanks to our guest panelist, Dr. Uche Blackstock, University of Chicago, and Elena Mendez Escobar from Boston Medical Center. We'll see you again next time. Have a great rest of the afternoon, everyone. Thanks for joining us.
Thank you.